So I got a call from Avdut. He says that I need to introduce, just mention the speaker's name first and then start my lecture. So we'll do so.
That's okay.
Level. आज के topics.
Okay, we are live. Good afternoon, everyone. We welcome you all to Ortho TV Online. Today's webinar is on cartilage 360 degrees, and today's chairman is Dr. Krunal Shah with the expert panelist Dr. Nilesh and Dr. Sanjay Trivedi. So over to Dr. Krunal Shah.
Thank you, Neeraj. Thank you for that all technical support, and I welcome you all, the viewers, for today's webinar on case-based discussion, specifically Cartilage 360. And I welcome all the speakers with me. We have Dr. Manit Arora from Fortis, Chandigarh, and I have Dhrumil Patel from Baroda. We have Dr. Manoj Mehta from Baroda, Dr. Prathamesh Jain from Ahmedabad, and we'll be missing Kalpesh Bhai today for his ill health. So with that, I start my talk on the first talk. Friends, this is a case-based discussion, and this is the case which comes into my mind whenever we discuss about the cartilage case, because this really changed my concept about the cartilage defect. He was a 30 years old male, and if I give you a brief clinical profile of him, he is basically a farm trader. So if I explain you, he used to go to all the farms and trade the farm related items to the farmers, specifically in the villages. So what I mean to convey is he has to walk on an uneven surface day in day out for 8 hours a day, and he was the only earning member of his family, basically coming from lower uh, socioeconomic class. There was actually no history of fall or trauma, and he had complaint of pain and swelling and locking in the knee since last 10 days. So he also is a brother of one of the general practitioner. When he came to me, he being a brother of a doctor, he was already been seen by 3 orthopedic surgeon and worked up. And what I noticed in a plain X-ray was there was some defect, which I can appreciate on the lateral femoral condyle in the X-ray, and it was very well shouting evident on the MRI. What I can appreciate is again a very huge defect on the lateral femoral condyle. And usually this is not the first time we are seeing this type of case. Lateral femoral condyle, most of the time it is insidious onset, sort of osteonecrotic defect, not actually traumatic. So even in your cases, when you come into uh, come with come to encounter this type of young fellows on the lateral femoral condyle, most of them, they do not have a very evident history of fall or trauma. Of course, when you inquire, they may give you some trivial trauma history, but majority of time it is sort of self osteonecrotic type of pathology. That's what I realized when I referred the literature regarding this. So it was a huge defect. So now three things came into my mind. The options, what I should do was, first is autologous chondrocyte implantation, then osteochondral grafts, and the third is of course microfracture. Honestly speaking, my option or my first choice was ACI, the recent generation ACI. But the reason being, it gives a homogeneous type 2 collagen cartilage on the defect, and he being a young active person probably can give a better result. When I explained to him that he may need, his reluctancy was he was not willing to go for two-stage procedure, because in ACI you need to take up the graft and then you have to send it to lab, and probably then you have to do open procedure. I am not very good in doing arthroscopic ACI in this huge defect, so do a open ACI implantation. And the second thing was again the cost. The cost being basically in AC in osteochondral grafts, that is oats, which I prefer, is I can use that kit for 2 to 3 times, though it is a disposable kit, but usually my preference is to use 2 to 3 times. So the economy comes to third of the base of the charges of ACI if we consider as a whole. So he being a lower middle socioeconomic class, his preference for this two reason was to go for, when I described all, was osteochondral graft. Third, microfracture anytime, not my option in this huge defect. Probably my fellow speaker will throw more light on that. Why? So uh, we can do oats basically arthroscopic or open. I have tried both the ways. I did around 11 cases of oats so far. Some of them initial in my career were arthroscopic, but honestly speaking, I have shifted completely on the open one, being basically we do not get that trajectory in large cigars, and in my hands I have seen some incongruency at the end of the procedure. So no, none of my patient had complained about those scars, and I do most of the oats now open. So this was the intraoperative image. What you can notice is there was a huge defect. It was around 3 into 4 centimeter, and uh, this is 8 millimeter cigars which I have used in the defect, and this is at the end picture of the procedure. uh, One of the reason doing ACI, we can sometimes use this. What you can notice of this locking problem is there is a huge loose body which is appreciable in the lateral gutter, and sometimes we can remove it arthroscopically. We can send it to the lab, and they can give us good result on that. So my rehab protocol is I start ROM a third day. I kept him non-wet bearing for 3 days. And total 3 weeks, and then uh, third week I started toe touch wet bearing, and gradual partial to full wet bearing I started after 6 weeks, and running is permitted after 3 months. These are some of the post-op MRIs, and I'm sorry. What I can appreciate is the osteochondral graft has been very well taken up, and I can see a continuity signals into the cartilage of the native cartilage. So, and there is no defect which is appreciable. Basically, I wanted for this, for the presentation purpose, I tried to convince 6 of my patient doing a redo arthroscopy. Majority of them I tried to convince doing free of charge and on their day of convenience for making a good presentation. But honestly speaking, this patient did not had any complaint, and they were not very well convinced for doing any type of procedure. So that speaks about the results of this type of procedure, and that raises a very big question whether we are theoretically overdoing ACI, or whether this type of osteochondral grafts or oats can be done in this huge defect and with good results, specifically in our type of Indian case scenario where budget does matter about the surgery. So these are the post-op MRIs. If I share the clinical results, uh, patient after 6 months was able to do almost all the activities, started his work also, and did not, as I said, it is majority of time I had to convince him to do the follow-ups and MRI and everything, because he personally did not had any complaint. So that's end of my talk about osteochondral defect. And now I invite a good friend of mine, Manit, for his talk on microfracture and micro drilling. Uh,
I'm sorry interrupting you, Krunal. Are we discussing the things at the end of the whole talk, or how we are going to plan the question and answers?
so we can do it both the ways as per your preference.
Because what will happen that once you go through all the things and there will be clutter in the mind about the information about that talk. So first question I would like to ask you is what is your basic understanding about an ACI particularly if you prefer to do in such a case which is non-traumatic. So, what is your understanding of doing ACI for a large defect like this? What will be the ideal situation?
So this is the ideal situation, honestly, for the ACI, autologous chondrocyte implantation, a defect of 4 into 3 centimeters in a young
That is
fellow.
that is one dimension of the indication. But see, in most of these patients where you do not have trauma or any other insidious means like any activating factors in terms of trauma, it is usually the subchondral bone which is the culprit. So one has to be very, very clear about using ACI even in the larger defects. And supposing if you were doing ACI, what would have been your criteria of doing ACI in this patient? What would you take care?
So I'm always more conservative in rehab, and whenever I have
No, no,
done.
no, no, not apart from rehab. First, as a surgeon, when you have more than 2 centimeters square or 4 centimeters square defect, this was 4 by 3, as you said. So that's one criteria indication which is good for ACI. It's a large defect, weight bearing area. But what would you assess in terms of the condition of your subchondral bone?
Uh, what I can appreciate in the MRI regarding the subchondral bone, there is definitely some sort of diseased bone and not a very healthy bone as we see in the traumatic defects, of
So
course.
the
But that does not prevent me doing ACI in this type of cases, because
no,
there are been
the
more literatures
world
now in support of ACI even in non-traumatic cases also. So
see, we've been doing ACI for this defects, but the consensus world over is that if you have more than 6 mm of depth, if the lesion depth is more 6 to 7 mm, then you have to graft it, and then you can do ACI. So what you ended up doing was the right thing because you have a osteochondral cigars or plugs, whatever you call it, that takes care of the deceased osteochondral whole junction, and subchondral bone is also replaced with the healthy bone, and that's why you're having a better result. If you had just put in only ACI on this defect, it would have been maybe menza result. So
I think that's
subchondral bone.
a valid and a
Nahi,
very
this is the main take home message for this discussion, that subchondral bone, if you don't assess in terms of its metabolism, its viability, then we are going to have problem with any type of procedures. So what you ended up doing because of the economic reasons, maybe whatever single shot surgery you wanted to get back early because that's a protracted rehab in ACI. So that's why your patient did well because maybe whatever reason, the oats was the right procedure for this kind of, you know,
yeah, I
hardworking
get you.
guys. Yeah.
I
So
get you. I get you.
subchondral bone is the key issue in all this disease when you do not have a severe trauma or specific event where you can relate that this is because of trauma. So that was one thing. Otherwise, I think oats has been standing test of the time for specific indications where you are doing a proper job in the sense proper indication, and it has to be open. Such a posteriorly going defect, you cannot be a hero doing arthroscopically. So that is another thing that you have to do it open only if you want to have proper orientation, its congruence, everything. Arthroscopically, you cannot do this job well.
I agree.
Even in the most experienced arthroscopic surgeon, this will be a huge thing. So, anybody else joining in wants to ask any question?
One of the things which I want to mention is post-operatively in this type of cases when I use the 10 or 8 plugs, I do find host site grunting, specifically patellofemoral. They have this. They do not pain or they do not complain anything, but when they sit down and stand up, they always have this grunting type of sound
Yeah,
or feel.
that will be incongruence there because you were
True.
going for 8 mm graph, which is a
Yes.
big size.
Yes.
But I think if you started the passive range of motion early, as you said, third day you started range,
Hmm.
so probably that will also heal up over a period of time. And as you gain the quadriceps strength back in isometric range, that is in TX, probably over a period of time that should also go away.
Not only in this case, even in some of my other cases, which I have I had opportunity to do follow up after 2 years around because of some other reasons, and I noticed them. They did not complain anything, but when I examined them, what I noticed is that it is not a normal patellofemoral a smooth motion. They do have some sort of clicking sound coming out from there, which
That's see, most of the time it's related to the quadriceps imbalance, which increases the PFJ pressure. And especially when you allow these people to squat as early as you said, it's quite early in your case, this is going to happen. And that will lead to early chondral disease, which is a secondary loss. And once you have this type of procedure, to do a quadriceps strengthening is a very, very balancing act. There is no general rule that you start open chain right away, because open chain gives you more strength, but at the cost of cartilage. So as a individual sports persons and sports medicine practitioners, we have to, tailor make all your rehab individually, and you need to teach your rehab guys that this is what is the safe range and this is where you want to work on, because they are always smart enough in social media promotion and everything, that we know this and that, but they don't know anything. So you have to tell them, this is what a range I want, this is a closed chain I want, this is an open chain I want. In all the respects, we have to be very, very thorough, because these are not daily surgeries. You don't do OTS or ACI every day, and these are
agree.
usually young patients. So we have to be very, very specific about our rehab advices, and we have to supervise that. And you will have scarring in that area even if you do arthroscopic biopsy for the ACI, because fat pad you have to resect, otherwise you cannot see. And that's why I use now, a 5 harvester. We don't
That is
use the
what I
7.
when I went through the literature and the experiences of some of the people which I
Yeah,
met even abroad, who are doing quite a lot cartilage
yeah.
surgeries. What they were telling me is
So
the 6 is max plugs which you should use
yeah,
whenever we are
so
doing force.
even for the harvesting we use 5 one. So you may take two plugs absolutely at the peripheral area, so you will have less of this problem.
That's what maybe a second take-home message, that 6
Yeah,
or maybe 5 to 6 harvest probably is
yeah.
the optimal
And
and should not be
yeah, and you may
greedy in
have,
taking.
yeah, you may have more plugs.
Okay,
Yeah,
agree.
I think. Anyone else in the crowd, anybody has joined, if they won't have any questions for you, just you ask them.
Any
Maybe I can
questions?
see.
Any questions on the chat box also, Neeraj? If we can see, we can ask, or we should say we should switch over to the next talk by Manit.
Yeah, go ahead.
So Manit is from Mohali, Fortis, and a very good friend. So I invite him for the next talk on microfracture. Thank you, Manit.
Thank you.
Great, thank you, sir. I'll just bring up my screen. So I'm talking on microfracture, and I thought instead of presenting the old boring cases about microfracture, I would present something which is a bit more interesting, a bit more controversial. So this is a high-level athlete who basically came to my boss when I was doing my fellowship. So he was a 28-year-old player. He played for the Fremantle Dockers in the Australian Football League. He had a hyperextension knee injury while playing. The X-ray was pretty unremarkable. It didn't really show anything major. So this was his MRI. And I thought I'd just make it interactive. So what's your diagnosis? So let's just send it around the crowd and see what do you guys think is going on.
Sorry,
So I think,
everybody is muted. Let me unmute them. Wait, hold on.
okay.
Hello.
Yeah, Dr.
Yeah.
Krunal.
Yeah, so we can notice some subchondral signal changes in the bone, and definitely some bone marrow changes also. Not able to pick up the diagnosis though. Perfect.
It looks like more of a delamination type with a subchondral bone edema and injury, as he was saying about hyperextension kind of injury.
Right. And what about the marrow changes upstairs?
Yeah, it is
That's what
there.
that's
So
unusual of
with
that
this,
red marrow thing or something. I don't know whether it is a red marrow. It's a traumatic thing because he being a athlete, not able to pick up the
so we,
diagnosis.
we sent these films across to one of the best guys around for radiology, and he came back and said that there's osteochondral defect, obviously, and maybe SONC, even though SONC doesn't get used anymore, I know. So it's a BOML or a BMI, but that's what they were suspecting higher up in the femur, that there was concomitant pathology. So he probably had weakening of the bone architecture, subchondral bone became fatigue fractured in a way, and ended up with this defect. So the player and coach, they basically wanted no time, no waste. They wanted him back ASAP. It was a very high profile case out in the media, everything. The family was all about money, money, money. So the more time away from sport, as you know, the more money you lose. So we went in and we found this. So there was a big defect there in the cartilage. So he had a good bump of bone along the sides, some fraying inferiorly, but generally a good wall for the defect. So we decided, controversially, this could have gone Oates' way as well, but we decided to do a microfracture for simplicity, earlier rehab, and get him back because of the demands of his sport to be back straight away. So, would you guys have done an Oates in him?
Yeah.
Yeah,
See,
So
no.
first of all, as you said, there was a problem with his subchondral bone as well as the epiphyseal area. His epiphyseal metaphyseal bone doesn't look that great. So even though money, 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 whatever the issue was, as a clinician, we need to basically have his bone metabolism checked before
Yes,
we offer him anything vis-a-vis whether he wants to get back early to the field. And with this big defect, the bone looks good, subchondral bone. So a
yes,
microfracture may be an escape button just to get him back and keep everybody happy. But
yeah,
long-term results may not be great on this.
exactly.
if we just quote a Brian College uh, prospective study, he had this all athlete study and quoted and reviewed that after 2 years they start deteriorating once we do micro fractures compared to OATS and MCI, so
Yes,
ACI. So probably that is one of the concerns here when we offer him
hmm,
micro fracture.
absolutely. Anyone else?
And as
And
you
the
are
second thing
saying,
is they are basically type 1 collagen in microfracture, what they find out in the histopathological examination. So not exactly type 2 collagen. So that also is a concern for an athlete, for a professional athlete.
So he's 28, near the end of his playing career. Like a lot of other factors come into play here. So usually these AFL guys, they peak out at about 32, 33. So he's basically got, I know we talk about long-term health of cartilage and all that, but at that age, in that sort of sport and with the external pressures that come on them, they're really only
yeah,
focused,
means
as you know, with any international player, just on playing. They don't really care about the long-term
yeah,
outcomes, even
means
though we tell
the
it to them and explain it to them. But for them, the most important thing is just play, play, play.
yeah, means if that's the main context of the treatment, then they come in from the ghettos and they go back to ghettos. That's a very standard refrain in the
Right.
Western world.
So I would
Because
have probably done oats in this.
yeah,
Yeah. So I was just presenting it because it's controversial. So one of the things I
yeah,
wanted
yeah.
to show was the micro pick. So I've been using much and much more of this now in my practice, and I find
Okay,
that it has some really good results for microfracturing, even for micro drilling, the 3D micro drilling that we used to do before. So it works
yeah,
really well in those cases as well. So 4 years later, the knee scores are great because he won a championship and he was one of the key players on the team to win a championship. So he's at 32, 33. Now he's about 34. He's still playing in the last legs of his season. So obviously his knee scores are doing great and he's come back, he's followed up. So I emailed my boss before this and he said that he's doing nicely. So, of course, there's horror stories as well of microfracture. So, if you know about Greg Oden, so Greg Oden was number one NBA draft pick. He was estimated to make about 45 million US dollars per year, potential All Star. The first season of his career, he had a big injury. He had a microfracture, which was done by my friend, and he was never the same.